Hello everyone, welcome back to the channel. I'm Dr. Abin, an interventional radiology resident, and today we're going to talk about a minimally invasive procedure that has been changing the game for women dealing with symptomatic uterine fibroids. That is uterine artery embolization or UAE. Now, who is this surgery for? Now, uterine artery embolization is typically recommended for people with symptomatic uterine fibroids that is causing heavy bleeding or bulk related symptoms like pressure, bloating, or urinary frequency. It can be used in adenomyosis in selective cases and patients who desire to preserve their uterus but aren't planning on a future pregnancy. And we can also do this in cases of postpartum hemorrhage, uterine AV malformation, or in selective cases of abnormal uterine bleeding. So when do you not do it? That is when there is a pregnancy or there is an active pelvic inflammation. And the relative contraindications can be an isolated submucosal fibroid or an isolated subserosal fibroid that is pedunculated, or it's a fibroid that is supplied by the ovarian artery. And even when GnRH analog treatment has been given in the past 3 months, you don't prefer to do a UAE. So what are the things you need before the surgery? Definitely you need a detailed history and a physical examination. You have to do pelvic imaging. So the first line would be ultrasound, but the best would be an MRI. And laboratory test, you need all the routine investigations like CBC, RFT, PTINR, HIV, HbSAg, HCV, LFT, and serum electrolytes, all the basic investigations. And the most important thing is counseling the patient. You should tell them the risk, the benefits. You should moderate the expectations, and you should also talk about the fertility implications also. So on MRI, the fibroids are usually hypo-intense on T2, but the fibroids that are usually hyper-intense compared to the adjacent myometrium, they tend to have a better volume reduction after a uterine artery embolization. So here in this MRI, this is the uterus, and this over here is the fibroid. And this thin rim is the endometrial cavity, and this dark thing is the myometrium. So if you see, there are these light areas, so it is hyper intense. The fibroid is hyper intense compared to the dark myometrium. So these fibroids have a good response and a good volume reduction after uterine artery embolization. And then there are these fibroids that have a T1 hyperintensity, and here the content will be a hemorrhagic necrosis, or that is fat within the fibroid. So they have a less response, they don't have a great response. And then location is also pretty important, because the best response we will get will be with the submucosal fibroids, and then you have the intramural, and the least reduction in size will be with the subserosal fibroids. And also on T1 post contrast imaging, so this is after the contrast, so here you can see the fibroid is lighting up, and in fact it is more bright than the adjacent myometrium. So these fibroids with significant enhancement compared to the myometrium, these have a better volume reduction than hypo-enhancing fibroids after uterine artery embolization. So once we come into the procedure, we will start with the common femoral artery access. So once you take a vascular access over here, you will pass a catheter. So usually we use a Cobra, and less rarely we use a Roberts uterine artery catheter. So you take a catheter over here. From the aortic bifurcation, you navigate into the common iliac artery, and from there you go into the internal iliac artery. And this uterine artery is a branch of internal iliac artery. From there you can use a microcatheter if you want, and with a microcatheter you enter into the small uterine artery. Once you have reached the point where you want to reach, that is the uterine artery, you can start with the embolization, and embolizing agents can be many. You can go ahead with PVA or embospheres or gelatin. And when do you stop embolization? You stop it when there is a significant reduction in the vascularity, or you're finding a flow stasis within the uterine artery. Now once you're done with all this, you take out the catheter from here and you will cannulate the same side uterine artery. So again you take out from here, and with the Cobra you can enter directly into the ipsilateral iliac artery, or sometimes what you can do is you can form a Waltman loop, and then you can come and enter the internal iliac artery, and again uterine artery, and you do the same procedure again. Once this is all done, both areas you get a good flow stasis, you take out the catheter, and you take out the vascular sheath also. And usually the vascular access sheath we use is usually 5 French. So 5 French, you can go ahead with just compression, and that will do it. So here again you can see this is the uterine artery, this is the uterus, and this is a fibroid, and this is the uterine artery that is supplying the uterine fibroid. So you take the microcatheter up till here, and here if you see, this is the microcatheter and this is the angiogram. So this is the uterine artery over here, and these are the tortuous vessels that is supplying the fibroid. So at this point you start injecting these small PVA particles, and these small PVA particles will go distally into the fibroid, and that will cause infarction of the fibroid, and hence there will be reduction in size. So this is the post embolization angiogram. Here you can see, you can only see the proximal uterine artery over here. And you can see all these tortuous uterine artery branches, they're all gone, the ones that is feeding the fibroid. And here you can see, this is a prior to the embolization, this is a T1 post contrast image, and you can see the fibroid is enhancing. And this is a 6-month follow-up of that same patient. You can see here the fibroid is not enhancing anymore, so that shows that the fibroid has infarcted, and in fact there is a reduction in size if you see, and the fibroid has also reduced in size, and the patient is also symptom free at the follow-up. Here if you see, this is an ipsilateral uterine artery angiogram, and there's a right-sided angiogram, and this is the uterine artery, and you can see all these tortuous vessels that is supplying the fibroid. You can see a spherical shape, that is the fibroid that is showing a vascular blush, and this is of the left side, and this is the uterine artery, and again all these tortuous vessels that is supplying the fibroid. And here the main concept is, you see this is a cervico-vaginal branch. So you always, when you start embolizing, you have to go distal to the branch and you should start embolizing it. So you keep the microcatheter after this. So here you can see, this is the main catheter, following which you have the small microcatheter, and that has passed distal to this. So that branch is likely here, and this has gone distal to it, and this is the angiogram after that. And from here you can start embolizing it. In embolizing agents, we have a lot of options, but however the top 3 will be a spherical PVA, then a non-spherical PVA, and gelatin. So in non-spherical PVA, the issue is the size is irregular, and they tend to occlude the perivascular fibroid plexus. So that will cause a lot of inflammation, and there are chances of partial recanalization later. So the good thing about spherical PVA, embospheres, etc. is that they are of regular shape, they are compressible, and they have more distal penetration, and they have lesser recanalization rates also. So spherical PVA embospheres are better than non-spherical PVAs, and also you can use gelatin also. So here in the top you can see, these are all non-spherical PVA particles. They are all color coded with different sizes. This is 250 to 350 micrometers, and here this is 45 to 150, and all these different colors have different size ranges, so they're not of an exact same range. And this is how you prepare it. You take it with a bit of a contrast and bit of saline, and this is how you prepare, and this is how you inject it. Now the main concept is, you have to take care of the sizes. The uterovarian anastomosis size is a 350 micrometers. So you have to use materials, that particles the size of which the sizes are more than 350 micrometers, so that unknowingly the particles don't go from the uterine artery to the ovarian artery, and that won't mess up the ovarian reserve. So you don't want non-target embolization. So for that you have to choose particle size more than 350. 350 to 500 is good, and 500 to 700 is also good. So many articles say 500 to 750 is good. By the latest studies say that both are equally good, that is 350 to 500 and 500 to 700. So the post-procedure patient is expected to have some amount of pain, and NSAIDs is more than enough, and sometimes you can give narcotics also. Nausea, vomiting can also be there, and you should use a liberal use of IV antiemetics for these patients, and you should always monitor for complications also. You should do a follow-up imaging, that is between 3 to 6 months, that is you can use USG or MRI. And when you come to complications, the main issues are post-embolization syndrome, that is like we told before, pain, fever, nausea. And the worst problems are non-target embolization, where you hit the ovarian arteries, infections like endometritis, abscesses, amenorrhea, or uterine necrosis. Now the references I use for this video is, the first one is a very beautiful article and I have learned a lot from this article, and all of you should read this. It is Evidence in Uterine Artery Embolization, a radiologist primer, and the other two are standard textbooks of interventional radiology. Thank you.